enhance the contrast between tissues. What I found out is that I tried everything. I tried the brilliant blue, tried the green, but in the dual blue, trypan blue, and brilliant blue, the trypan blue, the regular capsule dye makes the contrast really nice and visible, and it is important for us to try to dissect as much membrane as we can. Another finding that is also to be published soon is whenever we remove the lens, there is a risk of the retina going back to be attached, to be adherent to each other. Maybe this is the raw surface created by the maneuvers or so, I don't know. But the tendency has a lot decreased if we use densiron. Densiron is a heavy silicone oil. It's like perfluorocarbon liquid, PFCl. It's heavy, so I inject enough to keep the retina aside, not to let the retina go back and adhere one more time. And this, I think, is a breakthrough in management of stage 5 ROP. So it's left for 3 to 4 weeks, and we have to take it out because it does induce some inflammatory response. This is how the patient presented, and this is 4 weeks later at the time of densiron removal. You can see the flattening of the retina. You can see it's an open funnel detachment. We can appreciate the choroidal reflux. The retina is not yet in position. It's an open funnel configuration, and the child would see. Eventually, this child that was totally blind would eventually see. So the concept and the experience would give us an insight in further management. So this is another child who was managed by the same condition. Sometimes the peripheral adhesion can grow back because we inject enough to just keep the retina flat or in a more flat position. So here you can see that there are some peripheral adhesions that grew up despite the central part being totally flat. And totally flat equals good vision, decent vision for those children. So the beauty of the technique as well is that we can go and revise at the time of densiron removal, heavy silicone oil removal. You can see the retina is flat. We can go back and remove the further anterior adhesions to be able to allow the retina to snap back in position. The retina goes back in position by the function of the retinal pigment epithelium. So it's not like a conventional detachment like the ones you saw yesterday. We have to reapposite the retina. No, we free only. This is a tractional detachment where we only free the retina and leave the funnel open so that the RPE pump will pump out the subretinal fluid, and hopefully it will go back in position. So we can go back and revise. We can appreciate the nice red reflex. We re-inject the blue to stain the small peripheral adhesions and remove as much as we can of the very far peripheral adhesions as well. And we have to always remember not to induce a break because of the extreme thinness and the adhesion of the retina to the surrounding peripheral tissue. We keep going like slowly and steadily, and this is what we can achieve with this poor child. This is a young lady, young girl, and you can see that she could see with an effective correction. She has ambulatory vision. She's depending on herself, even in the minor things, and this is definitely away from true practice. So 120 cases were operated with such a technique. 80 cases with that sparing technique, stage 4, totally 80 cases. We saved the lens in like 80% of those cases, and we could achieve anatomical success of 8%. Silicone oil was used, meaning that I induced the break in 10%, and we failed 10% of those cases. Stage 5, 48 cases, only anatomical success could be achieved in 35.5% of cases. The use of densiron, it's a more recent event. The densiron presence is commercially available recently. So looking at those patients, we use densiron, the success mounts up to about 60%. And I think this is very miraculous. I used to tell the patient's family that I can be anatomically successful in 10 to 20% only of the cases. So if you raise up this to 40%, to double up this, or maybe triple up this, this is for me is something that really needs to be looked at more thoroughly and investigated more thoroughly. So this is a topic I just want to just let you know that we don't lose hope. Okay, we have to know the stages of retinopathy of prematurity. We have to recognize and identify those kids that are at risk. Dr. Olilaya yesterday, as I mentioned, did a great job. I know Dr. Kukula also from Lauren, she came and trained with me a long time ago, is interested, and we really have to make the move forward to the neonatologists to be able to break the ice that exists between us and to save more eyes. Definitely when we go and talk to them and tell them that we aim at the better health, better being of those babies, you take really tremendous care to make them go through difficult moments. We have a common ground for discussion. So it's very important, and I think also the National Eye Center has an important role in legislating this. So if we have an amendment by the Ministry of Health obliging the neonatologist to have for the kids to have an initial eye exam at 4 weeks, you will be having no blindness from retinopathy of prematurity in Nigeria. And I think this is very important also to look at. If this happens, we don't lose hope. There are things we can help with, and there are things we can try to get some vision back to those kids. So this is the initial presentation. It was supposed to be the last, but I just wanted to start with one more thing to add. I think many of you have come to Egypt last December. I think 10 of the Nigerian friends, mostly ladies and gentlemen as well, to the ophthalmic oncology meeting. This was a very new event in the Middle East area in Africa. We had really distinguished staff from all over the world, and I think the hearing was very positive. The feedback was very positive. So just mark your calendar. In April of next year, the weather in Cairo is still good, and we hope to see you more. We'll be having more news about entities, about it's nice to group the tumor stuff in 2 days and have an idea about what's going on in that field as well. So I welcome any questions. I mean, if you'd like, because we go through different topics. So if you have any questions on that. Guys, this is a breakfast meeting, so I'm having my coffee and you are relaxed. So please, yes, please.
Thank you very much for the presentation, Prof. My question is about what the prognostic factors would be for these children that have stage 4, stage 5 ROP. Like, what would determine who would have a good outcome compared to who would have a bad outcome? So is it about how long after they become blind, how long after the damage from the ROP has happened? Like, okay, like if I see a 2-year-old child that has stage 5 ROP, is it still worthwhile to try this kind of thing? Or I have to do it within the first 6 months?
That is an excellent question. The progression to stage 4 or 5 will depend mainly on the initial presentation, because ROP has different stages, and if the disease is worse, people would go to stage 5. If it's less worse, they will go into stage 4. I just operated a 4-year-old child who's coming from Syria, I think, a couple of months ago. And he had ROP, and to my judgment, he was still operable because of so many factors. He could identify light. The retina didn't look so fibrotic, though it was detached, and it was not really a good detachment, but it looked healthy. And the subretinal fluid, we do an ultrasound also. If the subretinal fluid is not hemorrhagic, or there is cholesterol in the back of behind the retina, I go for surgery. So, and it went really fine. The surgery went fine. The best thing is not to have this, is to go for the screening, and at 1 month we inject, and that's it. we identify the bad eyes and inject anterior. That's it. So the second worst or second best would be to identify early and timely intervene to prevent progression. So if you have, as I showed you, the macular dragging on a flat retina, you go and you do tear vitrectomy and you thoroughly cut the anteroposterior traction forces and the retina will just go back in position. So if you have those complicated cases, the judgment will depend on so many factors. And I always push the family away from surgery because I know that whatever I would counsel them for, their expectation is extremely high. And they're really angry at somebody, they're angry at the pediatrician, at the gynecologist. I'd rather them to be angry, not at me at this stage. So I just push them away from surgery. I tell them when we regularly do surgery, we have over 90% success. Now what I'm telling you, I'm having 10% success, so I'll be having 90% failure. And you have to accept this or just leave it. Leave it be. Okay, so nobody had breakfast yet, right? So I got that question. So no, it's this. And the retinoblastoma. So if you have any preferences, we can do either, depending on what you see. Like proptosis first, retinoblastoma first. No votes? Retinoblastoma. Okay. Right. We have very specialized centers in Egypt dealing with retinoblastoma since 2003. One of them was the National Eye Center, where the department has been established. I could establish the department there in 2003, and also the private hospital where we see many of the cases. I would just recognize and identify the friends here. So Dupi, among other friends, he did a good job in Egypt years back. So the retinoblastoma is still the common primary intraocular malignancy of all age groups. Actually, it's not only of pediatric age group because of the frequency of retinoblastoma. It's of all age group. It comes from primitive retinoblast with cone differentiation. It was recognized since the 1600, and it's second to choroidal melanoma in all age groups. Diagnosis is mostly clinical, and it happens in 15 to 20,000 lives. So mainly two main centers in Egypt, the National Eye Center and the private hospital. It's expected to have 120 to 150 new cases a year. Many of those are unilateral, and those pose no really big problem because like 75% of those will end up by irritation, good irritation, and 25% of those we could save the eyes, and minority is bilateral disease, and this pose the real challenge in management. So the positive factors in Egypt is that we have the trained personnel, we have a dedicated public and private hospital program, the availability of care. Of course, the RETCAM is an essential part, the ultrasound, the systemic investigation, of course, the lab and everything, the adjuvant chemotherapy through a pediatric oncologist, all the lines of management are present, thermotherapy, the brachytherapy is present, the selective ophthalmic artery injection also is present, and there is a social support system. Cancer costs a lot. So to be able to manage a child with retinoblastoma, we have to have at least a 1-year treatment program, 6 months of active treatment and 6 months of follow-up. And whatever people are rich or poor, usually they cannot afford this. So this can be done through a government subsidy. The people, they should be sponsored. Those children would die if they are not sponsored. So this should be a system, and I think it would be very expensive to acquire every tool and item in the management. For instance, the brachytherapy, the radioactive plaque used in retinoblastoma occurs in like 10 to 15% of cases. We need an active plaque to be put on the tumor to eradicate the tumor. So it's not cost effective to have like in every part of the country, or even in the country, radioactive plaques. They would be used, and though being very expensive as well, once a year or twice a year. So here comes the regional collaboration, the continent collaboration. I think, having a center of excellence in Egypt with the collaboration maybe with the folks in here would allow better care and better service of those kids until Nigeria becomes the center for West Africa, until people will be trained enough and interested enough to do that. So we have to remember when we deal with a deadly cancer that we always have to think about saving life. So this is not an eye that is not seeing, or it is seeing, and we want the eye to be seeing better. This is not an eye that we had a complication and we end up by losing the eye, an expulsive hemorrhage, infection, or whatever. This is a child's life. And this is totally different. It's a totally different concept to think about it, because we are not killers, right, by nature, being human. We are not killers being doctors as well, right? So the single mistake, if you open a child's eye with retinoblastoma, if we take a deep stitch while doing enucleation, and the vitreous will seep out into the orbit, this child will die by our hands in 6 months' time. And it's very important to differentiate, which is a big topic here, to talk about, is this retinoblastoma? Maybe you can do a vitrectomy, and maybe you can open, we can take a biopsy. Maybe it's codes, maybe it's something else, So, and sometimes, believe me, it's very difficult. I see a lot of those cases, and sometimes I got squeezed in the differential of a highly lookalike similar lesion that is not, or may not be retinoblastoma. We are in the doubt of opening the eye or taking the eye out. Be aware of that. And it's just like, it's a human life. It's not like an eye that would be lost. So if you can control the tumor and save the eye, well and good. If you can control the tumor and save the eye and save some vision, better and better, right? So since the early 90s, chemotherapy has been introduced to reduce the tumor size, the bulk of the tumor, to make it amenable to further management. If you'd like to just take a snapshot of this link, this is the major review in the Saudi Ophthalmological journal. It's online, it's really accessible. You'll find many of the information of this lecture on that site. Good, I'm back. So the children younger than 10 years, we have 6 per million. Younger than 5 years, it's 11 per million. And also, this is very important because the bigger the child, we are swayed not to think about retinoblastoma. And this poses problems. I had a patient from Libya coming 2 months back. He has been treated from uveitis for the last 2 years. He went to France, he went to Tunisia, and they just gave him everything about uveitis. And you just go and see, I will show you the picture. It was amazing. I mean, just like, it was very surprising for the father that he would come and see me and I would say, we have to enucleate the eye. Yeah. But this was it. we don't tend to remember that retinoblastoma can come in elderly and it presents differently. So 1/3 of cases bilateral, familiar, and 90% on the other 2/3 are unilateral. Familiar cases are in 10%, but I think they are increasing because of the survival of the younger kids now. You know, the children I was treating 17 years back got married and they see their kids now. So we're getting older, we don't realize this. We have in our body, in normal humans, 2 retinoblastoma genes. And the retinoblastoma gene has a very important role. If you go back to the cell cycle, the cell growth cycle, most of our cells are in quiescent stage. Whenever there is a need, some signals will initiate cell division, depending on whether it's a skin cell, whether it's a cornea or limbal cell, a hair follicle cell. So the cell will go into a DNA synthesis phase, which is the S phase, and then growth, or pre-mitotic phase, and then mitosis, and the single cell will become 2 cells, right? So the normal hypophosphorylated active retinoblastoma gene, which is an autosomal dominant gene, in every cell of our body will come to this checkpoint between J1 and S phase. It will check the cell for, do we need the cell? Really, do we need another cell or not? And is the composition of that cell that is going to divide normal or not? So this is an extremely important checkpoint where the RB gene controls really unnecessary cell division, right? And it makes things wonderfully healthy when it goes from one cell to another cell. So it's an autosomal dominant gene. It has nothing to do with consanguineous marriage. Okay? Consanguineous marriage will show off recessive genes. And the ability of expression is really high. So if I have the retinoblastoma gene, 90% of the time I'll show this in my kids. So the ability to express on the penetrance is really high. Normal retinoblastoma gene is a tumor suppressor, anti-oncogene, and it's located on the location 1,4 long arm of chromosome 13, the band Q14. Q is the long arm of the chromosome, P is the short arm. It's rarely a relatively large base pairs gene, and it has to form an active hypophosphorylated form and an inactive hyperphosphorylated form. So what happens now if we lose both alleles, if we lose both dominant gene on that locus of the chromosome 13 on Q14 location? One of the methods is the hyperphosphorylation. The retinoblastoma gene gets hyperphosphorylated, or the protein carrying the gene gets attacked by some viruses. We don't know the triggering factor exactly, but the loss of the control point, the checkpoint between J1 and S phase, will allow continuous cell division. And uncontrolled cell division is by definition malignancy, right? So this is how it shows up and how it comes. We have to form the hereditary form or the familial form where one of the parents is affected by retinoblastoma gene. It might express it most of the time, or it might not express it. Having one sperm affected by the loss of the retinoblastoma gene will get all the cells of the body of the offspring liable to get cancer, right? Because at this stage, having a normal allele, a dominant, an autosomal dominant normal retinoblastoma gene will control cell division by itself, right? So the recessive lost gene will not induce malignancy at this point. So how come that this child will get malignancy? During the busy development of the retina, the bone cell, the precursor cell, which is really highly divisible and dividable in the first 2 years of life, in the first year of life. The cells grow so fast. It's easy to lose the other retinoblastoma allele, the tumor suppressor anti-oncogene. Okay? So a single mutation in a single cell that has lost already another dominant gene will end up by losing the other dominant gene. Okay? So this cell will grow with no control. And this is by definition malignancy and unphysiological cell growth. So if we are born with already very susceptible cells to get a tumor, it's easy during the first few months of development to lose in this single cell in the right and the left eye, or in multiple cells in the right and left eye, the other dominant gene, and get multiple cancers. So multiplicity is one important and essential issue in determining hereditary. This is the familial traits. So if we have even in one eye multicentric tumor, this guy will just be harboring the familial hereditary form of retinoblastoma and not the unilateral sporadic form of retinoblastoma. And this has the impact on counseling and seeing the kids of that child while he is growing up. And this explains also why the bilateral form comes before 1 year, right? Because with the rate of cell division, it's easy to lose the other allele. Sometimes we have this particular type of patient, low-set ears, mental retardation, some anomalies in genitalia, imperfect anus, thin upper lip, broad nasal bridge, and this would be the loss of the whole long arm of chromosome 13. Not only the Q14 location, but the whole long arm, and this is called the 13q chromosomal deletion. Sporadic forms, which is luckily the most prevalent forms of the disease, comes genetically different, because we have here a healthy child, a healthy father, and a healthy mother, actually, who have healthy offspring. The zygote carries the two dominant alleles, and he's apparently okay. What happens is that he has the two mutations happening in a single cell. So by the first hit or the first mutation, he loses the one retinoblastoma dominant gene, and by the second mutation, he loses the second dominant gene that is an anti-oncogene in the same cone cell or the same cone cell precursor. So for the tumor to develop, it takes time, because the child is born normal, and we, according to Knudsen, who made his two-hit hypothesis, and it stood the test of time as well, the happening of such an event will take time. And this is why unilateral retinoblastoma comes in elderly children at 2 years or beyond. So this is very important. I think it's very important to have a clear view and perspective of parents who would come for their genetic counseling. Because what would be the risk of subsequent child having retinoblastoma for those unilateral cases and bilateral cases? For those bilateral cases, if we have one affected parent and no affected child, 40% of the times this family will get a kid with retinoblastoma. If the parents are normal and one affected child, this is called the mosaic form, a rare form where the gene doesn't express itself. 10% of the kids will have retinoblastoma. If you have one affected child and one affected parent, 50% of the kids will have retinoblastoma. And this would tell us that it is very important, even during pregnancy, to ask the gynecologist or the obstetrician to do an ultrasound and to look into the eye. Because you know the obstetricians are automated. They just take the length, the girth of the head, and they don't look into other things, right? Unless we ask them to do. Not only that, we can have an amniocentesis before the 4th month and know and just do the karyotyping and know if the offspring is positive, negative, or we just don't know. We can do that, and we sometimes do it according to the parent's request. So if the patient comes with unilateral retinoblastoma and has an affected child, affected father, with no affected children, 3%, the incidence is 3%. And this is a whole lot of difference, right? It's a huge difference. So if this father would ask, can I have more babies? What would be the risk of having a child with retinoblastoma? We really have to tell him the truth, because they would make up their mind about what they want. So if the family is normal and they have one affected child, the risk is 3%. If they have one affected child and one affected father, the risk goes to 30%. Almost, this is the hereditary form of retinoblastoma. So history is very important to make the differential. The differential diagnosis is the long list of differential. So we have to ask about prematurity, ask about similar condition in the family, and the presentation. Usually, patients present with leukocoria and strabismus, and all strabismologists here would know the golden rule. Any patient presenting with strabismus, new onset squint, we have to dilate the eye to look for small tumors occupying the macular area and inducing sensory strabismus, right? This is the golden rule number one. The presentation might come to fixed diet, pupil, neovascular glaucoma, and heterochromia, and you always have to remember, always, that if a child comes with a spontaneous hyphema or unilateral ophthalmos, never believe the mother. The mother would say that the child was at school and he came and just we found out that the child he couldn't see out of his right eye. So we thought he got bumped or he got assaulted or something happened to the kid. So remember that trauma-inducing hyphema or vitreous hemorrhage should be severe enough to express itself on lid ecchymosis, conjunctival ecchymosis, conjunctival rupture, and so forth, right? So the next question would be, was he really traumatized? Did he have a black eye? No, he didn't. So you don't know. As a mother, you would speculate this. And you're swears if we're not vigilant enough away from the diagnosis of retinoblastoma. So here the counseling is extremely important. And remember this golden rule because it doesn't change with time. Pseudo-inflammatory presentation, this is how the kids present. This is a uveitis-like cases or an endophthalmitis-like case where the child, the grown-up child, the robust, well-built child that would come in a very attractive attire, and you wouldn't think of him as a kid, right? He's 11 years, he's very robust, he's well-built, and we don't think about retinoblastoma, and we don't remember that endophthalmitis has the simple ciliary injection, pain, another focus, constitutional symptoms, right? We just forget about this. This is a hypopion in a very quiet eye. The eye is extremely quiet. And if he's lucky, the eye wouldn't be opened before for biopsy or vitrectomy or glaucoma surgery. And these are real stories I'm telling you here. Tumor can outgrow the blood supply, and the tumor the tumor cells can die, and they induce an orbital pseudo-inflammatory condition. So remember also to look into the eye with patient presenting with orbital cellulitis-like condition or orbital inflammatory condition, because it can harbor a dying tumor inducing such a condition. If we neglect management, this is the natural history, proptosis, and really aggressive disease. So this is the natural history of untreated eye. The eye can be tricycle, and the child would still carry the hereditary form and the risk of regrowth of such a tumor. Tumor is brain-like, and calcification is present in 80% of cases. So the absence of calcification does not negate the diagnosis of retinoblastoma, because 20% of cases would have retinoblastoma. Tumor can grow towards the vitreous, it's called endophytic, or towards the choroid, it's called exophytic, and most tumors have combined growth pattern. This is a very dangerous pattern of retinoblastoma. 1.5 to 2% of the bigger adults would present with pseudohypopion, multiple biopsies, multiple vitrectomies, and nobody would think about having the biopsy sent to the pathologist. Pseudohypopion presents in a diffuse unilateral cases, and it should be really looked at thoroughly. The tricycle, the spontaneously regressed retinoblastoma retinomas, is a rare entity, about 5% of cases, and you can see different regression patterns in the same eye. You can see a tricycle eye, and you really have to follow them up, because I think 10 to 15% of those regrow over time. Tumor is very fragile, and it's very loose, and it tends to spread inside the eye, going into the anterior chamber, going into the optic nerve, going through the emissary to the orbit, going into the vitreous. And this is again the intraocular spread. And this is one more time, the collaboration with the pathologist. There is now the pathological TNM classification, that the pathologist should get a reply to a solid. So he would tell us what the enucleated eye TNM classification is. Scleral invasion can happen through the foramina or through the emissaries, and in here the tumor went from inside the eye through this scleral emissary to the subconjunctival or episcleral space, and the tumor here has gone out of the trabeculectomy website, surgical site, trabeculectomy opening in the sclera to outside the eye to an almost equal side of the eye. And you see how we can be neglectful and even denying having cancer at this point. So this is the golden rule number 5. Remember the golden rules. Tumor can go through the optic nerve, to the other optic nerve through the subarachnoid space, and tumor can go to the brain if the case is neglected. Tumor can go to the lymphatics. This is an enucleated globe. Remember not to let the new residents start up by enucleating retinoblastomas, right? Because, we tend to be, selective in what we do, and we think of enucleation as a bad thing, so the junior would go for it. The junior resident would go for it. If you want him to just end his career after perforating a globe with retinoblastoma and killing a child, you can do that. Otherwise, be merciful with him or her in the first soft years, where he really needs to learn a lot before proceeding with enucleation with retinoblastoma. So this child was enucleated. The stitch has gone into the vitreous. The consultant was not caring much about being besides the resident, and 6 months' time he comes with lymph nodes. And this child eventually dies in another 6 months' time after an awful journey of chemotherapy and radiotherapy and everything else. So the mortality comes with the invasion of the ocular coats, as you can see here, massive choroidal invasion, scleral invasion, and orbital invasion. And if you don't have a long stump of the optic nerve with 3 surgical margins, we have to really have a long stump of the optic nerve. Factors, also we hear no more about pinealoblastoma now because of the extensive use of the chemotherapy over the last 2 decades. And the patient tend to develop many other tumor or cancer in the body, especially if they were irradiated. So this is also not as much as before, because within the radiation field, when they used to treat retinoblastoma with radiation, 40 times more risk of getting one of those cancer within the radiation field or elsewhere. Metastasis is associated with optic nerve invasion, delay in management. Okay, so please, I would accept that you would take a salvageable eye out if you don't have other alternatives, or if the family is reluctant to go to a referral center or so. But please, do not leave it grow as I showed you and take the natural course, because this would be really disastrous to see the tumor growing out of the eye and going into the brain of the other eye, and the child coming with severe proptosis, and he will die in pain. So spend time with families. I know the cultural resistance that exists also in Egypt. Nowadays, things get better with whatever positive feedback we give them. The staging is important. We have the ABC staging system, ABCDE staging system. I don't want to go through this because it's there and nothing is new. But basically, group A and B, where the tumor is confined to the retina, would have 100% success rate in management. Small tumors or larger tumors, when they grow up beyond, a little bit beyond the retina, not a lot beyond the retina, with the presence of subretinal fluid, the success goes to 80, 85, 90%. When the tumor massively grows into the vitreous or subretinal fluid or the subretinal space, the success goes to maybe 50 to 60%. And I'll show you how. This is a massive tumor, hiding the nerve going to the back of the iris. These are the vitreous seeds, subretinal seeds. This is a group DI. Group EI, usually we should identify them because they are anti-valuable. These eyes will be happy to take them out and relieve the patient from a very advanced disease that is jeopardizing his life. So the The international classification ended up by concluding that the tumor dissemination treatment success decreased, and we have to emphasize about the early detection and improving our ways of approaching advanced disease to improve the outcome. Comes the TNM classification done by oncologists. Usually, whenever there is an oncological classification, we talk about human life, right? So if a patient has cancer, we talk, would he be cured, or would he die or survive, right? So this is the thing. But all the classification were done by ophthalmic oncologists that were very concerned about saving the eye. Saving the eye using radiotherapy, like the Reese-Ellsworth classification back in '64, or the Lynn Murphy classification in 2003 that was approved by the ophthalmic oncology community. So we were not talking about saving lives. So Dave Abramson, Paul Finger out of New York, he's an ophthalmic oncologist, and he came out with the TNM classification because there is a joint American cancer classification system that takes all the cancer in the body and talk about the TNM classification. And this would just unify the way management is done and assessed. Now, for us to say that your treatment method is better than the other group treatment method, they had to be classified according to TNM. For the first time in the AGCC book this year, they issued the TNM classification of all eye cancer. I would be glad if you email me to send them over to you. And it's very important for you guys to know it and try to classify your patient on that basis. Basically, what we talk about is the primary tumor, whether it is confined into the eye, not identifiable, or big enough, or going outside the eye with extraocular extension. So from T node to T4, we're talking about primary tumor, we're talking about regional lymph nodes, and we're talking about metastasis. Okay, the M is for metastasis. So we have to remember that it is a curable cancer. Retinoblastoma is a curable cancer, but it needs team group and team work on that to achieve this. The sad story here is the mortality, the amount of patients having problems in Africa. The death is really high, and I think we are talking the sub-Sahara part of the management, because I would claim that in Egypt we're fairly advanced in management, and we got the link with the northern part of Africa as well. We got the link with Algeria, with Tunisia, and with Sudan, maybe Morocco. A few cases come from Morocco as well. So we really have to have a center of excellence dealing with cancer, specifically with eye cancer, specifically with retinoblastoma. And I think one other would be in East Africa, and another one would be in West Africa. I was in South Africa last year, and they do a great job there. Just the people interested in that. So we have to really think strategic, because the way I got the center done in Egypt is I convinced the Minister of Health that this is an issue of national security. What if you have a red ocular surface lesion and turned out to be cancerous? What would you do at the time? And it worked. Just I got the center, I got everything. So many things to manage retinoblastoma, and the decision is really tailored to the patient's needs, and we have a whole bunch of lists. Remember that manipulation has to be really minimal manipulation. A very long optic nerve stump has to be taken away, and this would affect the survival of the patient. If we inspect the eye and we find no tumors outside the eye, believe that there is no tumor outside the eye. So put an implant, whatever it is. Just put a PMMA implant or a silicone implant or a hydroxyapatite implant. Whatever implant you just find suitable, put it, and just tie up the muscles around the implant, make the superior rectus loose a bit, not to induce post-operative ptosis, and the child will survive. Okay? Nice and happy. We moved from external beam radiotherapy because of the complications of radiotherapy, immediate complication like dermatitis, dry eye, bony orbital hypoplasia that show up later on in life. And the most important thing was radiation-induced malignancy. In those heritable cases that were irradiated, within the field of radiation, they got second cancer, really bad disease, sarcomas, and this is the main reason of death because the incidence is, as a rule of thumb, is 10% at 10 years, 20% at 20 years, and 30% at 30 years. So Mariam was one of the very early survivors. She got sarcoma as she had the predisposition, and we could save her limbs back in the late 80s and early 90s. This was a very challenging surgery with the orthopedist, and she survived the disease. The basic is in bilateral cases is to give intravenous chemotherapy with a target of chemoreduction. The tumor will shrink down, and this is the basis and concept in many other subspecialties in tumor in oncology, the neuroblastoma, the nephroblastoma. Many of the kids' cancer are given chemotherapy to shrink down and reduce the size of the tumor. We have to identify the types of regression, whether flat scar, 100% calcific tumor, like in here, or 100% fleshy, like in here, this is a regress tumor, or partially calcific, and we have to go for the percentage of calcification or a flat scar. So the chemoreduction is aiming at debulking the tumor, shrinking down the tumor, and 80% of the tumor goes away by the second cycle of chemotherapy. This is usually where we start our focal therapy because systemic chemotherapy does not work alone. If we give systemic chemotherapy for the rest of the life of the child, he will have complication and will have recurrence that is resistant to chemotherapy. So do not do this. Do not give chemotherapy hoping that things will go better. Things will never go better and will keep growing back. And people and the family would have spent so much money and would be denying or rejecting or refusing enucleation even when the tumor goes really out of the eye, like in this case. Please do not do that. This is another child who presented with a very amenable to treatment cancer, and he got the chemotherapy without focal therapy, and the tumor got an extensive recurrence. This is after plaque. He got shrunk down, and this was the initial presentation. The tumor was very focal. He could be really treated. It was a stage B disease. With a 100% success rate, he went elsewhere to chemotherapy, massive recurrence, and this is after brachytherapy. So chemotherapy does not work alone. You have to remember that. Chemotherapy is given monthly on 2 or 3 days basis for the next 6 months, and the child is achieved the cure. So the other thing, if you do cryotherapy for peripheral tumors, it's not like when crying for sterile buccal, the ice wall has to go beyond the tumor, and we do this 3 times: freezing, thawing, freezing, thawing, freezing, and thawing. I'm almost done, Dr. Hassan. Almost done. Now, give me like 2 more minutes. I deserve it after yesterday. Okay. 3 minutes. With chemotherapy from the second cycle, we give thermotherapy. And thermotherapy is a different concept of laser photocoagulation. In laser photocoagulation for diabetics, in PRP, we do surface RPE photoreceptor burn, right? And this temperature goes really high to 95 degrees. In thermotherapy, we give a large spot size, lower power, and deep penetration laser so that it goes 4 to 5 millimeters inside the tumor, inducing tumor necrosis. So in thermotherapy mode, if we have a superficial immediate burn, we know that we just burned the crust and we didn't go inside. The target is to go deeper, deeper, and deeper. This is done by indirect ophthalmoscopy laser with a large spot size delivery system. The machine is available. I don't think it's very expensive. And we combine usually thermotherapy, the heat, raising the temperature to 60 degrees with the chemotherapy so that they would have a synergistic effect. This is before and after. We can identify and recognize the effect of chemotherapy. This is the extensive tumor after chemotherapy. You know, it ended up by being the better seeing eye. The left and the right eye ended by being the better seeing eye. Brachytherapy is applying a plaque, a radioactive plaque. We use the ruthenium in Egypt to sterilize the tumor, destroying the vascular supply and negating the ability of reproduction. We have so many plaques in Egypt. We selected, we got the ruthenium because it's cost expensive, cost effective, and we can use the plaque for up to a year and a half time. And we have been using this since 2003 with wonderful results. This is a 2-week-old child. He's been given chemotherapy. He's the brother of a sister who had retinoblastoma, and the mother was coming shy with her child. And I said, "Who is this?" You know, when they're getting out, he said, "This is Ashraf, the sibling. How come he didn't get an eye exam?" I looked to his right eye. He's okay. I looked to the left eye, and I just realized what smooth skin is. You know, it's got the smooth skin of seeing the tumor. Anyway, so the brachytherapy is effective, and it works. The patients really need to have follow-up, and we achieve tumor control in a large majority of cases. The ophthalmic artery melphalan is really something that was introduced back in 2009. We have a nice trial about it, but this is another way of giving chemotherapy. But remember, it doesn't work alone. If you have a neuroradiologist here that is enthusiastic about it, it doesn't really work alone. So the thing is that we need to talk and to get interest group in subspecialty, and I think we don't have time. They will kill me. Well, if you have any questions, so we can take the question after the. Thank you.
Thank you so much, Prof Ihab. There's so much to do with the two topics he has talked on this morning, rope and retinoblastoma. But the message is that we cannot work alone. It's cross-cutting several specialties and education, and the professionals, the politicians, and the society. Thank you so much. Dubai, somebody who is actively working in retinoblastoma wants to say something? And what are the challenges? Abdurrahman?
Africa is even worse than that, because most of the patients present with either orbital disease or disseminated disease in other systems of the body. So it's basically a socio-economic problem, first of all, which makes it difficult for the patient to access care or to agree to treatment or to be able to afford the treatment even when he presents to us. So it's really, I agree with you, there is a problem of, we can call it national security, because we are talking about the life of a child or a family who has the mutation. You find a family that has many children with this kind of disease. We face a lot of challenges, but basically it's more of a socio-economic problem. And even in centers where you have the pediatricians, the oncologists, the ophthalmologists, you find out that the synergy between the different subspecialties to optimize the care of this patient may be lacking. Like my institution is basically a tertiary eye institution. So we do not have the benefit of having those other people to help us. And then it is like the referral center where we see up to 100 cases in a year. So it's quite challenging. Thank you.
You probably, I mean, after my training, I went back to Egypt in 2000, and I had this lecture. I was invited to give a lecture about retinoblastoma at the National Oncology Center. And you cannot imagine what was the number of attacks and bullets directed to me. Why? During my residency, whenever we encountered a patient with leukoporia, and the senior professor came and said, "This is retinoblastoma," we were just automatically sending him to the National Oncology Center. Okay? And we would just we're there to get rid of the child, not to bear the responsibility of initiation or so. So deliberately, we gave them the authority to treat our patients, and they could not examine a fundus, and they could not recognize a regress tumor or an active tumor or another way to be treated tumor. So what they did at the time was they irradiated the eye. They didn't put an implant, and they irradiated the eye for no good reason. The tumor was inside the eye. So taking this from them was a big challenge. So this was the first step that we say we're knowledgeable, we know about what we're doing, and we are the maestros, we are the guiding physicians into that. So once this, and this took a huge amount of effort because the people like what they do. They don't like this to be taken away when they right or wrong. The second thing is the frustration ophthalmologists meet when they see an eye with leukocoria, because what happens is they would know automatically that this will end up by being enucleated. Okay, we have to deal with those frustrations because we have alternatives. So the way is to have the horse in front of the car. We have the center, we have the knowledge, we have the know-how, and we have the group. And you will be amazed by the amount of patient referral we get. Third thing is the socioeconomic status of the patient and also the cultural acceptance of enucleation. I think we have the same cultural hindrance in Egypt and Nigeria. The socioeconomic, it's so easy to raise funds for a child that is going to die from a cancer in his eye. It's nothing. People just donate money to